welcome everyone. I'm Marika Russell, and I've been honored to be a part of the team here that's been putting together these endocrine section webinars, along with Joe Sharp, my colleague who you'll see here discussing surgical maneuvers later this evening. Under the leadership of Mike Singer and Brendan Stack, we really have had the honor and privilege to put together these educational seminars. And we've shifted gears a little bit, as you may know from the last. We've gone from really a focus on clinical management and clinical strategy to sort of the nuances of surgical skill, learning from our expert colleagues. So we're excited to bring you this second of two. The first, as you know, was on parathyroid surgery. This is now a webinar focused on thyroid surgery. So we have a real breadth of material here to share with you tonight. You will be able to claim a CME after this webinar. Look out for a link that will be sent by email. These are the disclosures of our panelists. And here is our agenda. We have Whitney Liddy from Northwestern, who will be our fearless moderator. We have an expert team of panelists. We have Dr. Lisa Orloff from Stanford, Joe Sharp from Cleveland Clinic, and Mark Zafario from MD Anderson. So we look forward to hearing their insights into some of these surgical techniques that they'll be discussing and showing us. Again, the focus here is on videos to give you a real sort of peek into how our expert colleagues do some of these challenging things and some of these routine things that we all perform on a regular basis. So you can see the objectives listed below. We hope you'll enjoy the material tonight, and I will have Whitney take it from here.
Thanks, Marika, and hi, everyone. I'm Whitney Liddy from Northwestern. I'm honored to be here tonight to moderate this incredible panel of expert thyroid surgeons. We saw a great first skills session not long ago on parathyroid surgery. Tonight, we'll focus on some of the technical aspects of thyroid surgery and neck dissection related to thyroid cancer. We're trying to focus on the more technical aspects of these operations, so won't spend as much time focusing on the workup and non-surgical management of thyroid disease. We're very lucky to have expert high volume thyroid surgeons with us tonight, who will probably do a lot of things similarly, but may think about things very differently as well. And so we're looking for those different perspectives as we move through the webinar tonight. For each topic, we'll focus on one panelist, but I'll ask different panelists to chime in if they have other thoughts. In terms of the topics we'll be discussing, we're going to start with Dr. Joe Sharp from the Cleveland Clinic with some special considerations regarding thyroid dissection in the setting of neoadjuvant therapy for anaplastic thyroid cancer. And then we'll move on to Dr. Lisa Orloff from Stanford with her thoughts on more nuanced portions of a central neck dissection, with particular attention to that right central neck, deep to the recurrent laryngeal nerve, as well as some thyroid cancer specific pearls regarding the lateral neck dissection, with particular attention to levels 4 and 5B, medial level 3. And then we'll move on to Dr. Mark Zafario from MD Anderson with some tips for how to deal with the trachea with those more advanced invasive thyroid cancers. And then finally, if we have time, the panelists have been asked to comment on potential management dilemmas related to when to sacrifice the recurrent laryngeal nerve in the setting of well-differentiated thyroid cancer, and also what to do about that contralateral side when there's concern for loss of signal of the nerve on the first side during thyroid surgery. Dr. Sharp has some slides he's willing to share that helps address some of these issues if we have time. So without further ado, we'll get started. I'm going to turn it over now to Dr. Sharp to talk about dissection in the setting of that neoadjuvant therapy.
Thank you very much. I'm going to be speaking about neoadjuvant treatment for anaplastic thyroid cancer. It's an area I've become very, very interested in, particularly with the protocol from MD Anderson that we've been involved with from Dr. Mark Zafario. So I have been doing some consulting work and interested in nerve monitoring. So the patient I'm presenting is a 70-year-old rocket scientist. He actually was a rocket scientist with an enlarging neck mass. Came to our ER this summer and had a core biopsy that did show anaplastic thyroid cancer. We get immediate immunohistochemistry to find that, and we also have a targeted oncology panel. He was worked up with imaging that did show concern for nodules in the lungs that were concerning for metastasis. And also within the brain, there was no abnormalities, but the neck was quite problematic. This is imaging, some select imaging of his cross-sectional views. You can see that the carotid artery is encased on the left side here. So he wasn't really deemed to be a very ideal surgical candidate. And so for this particular patient, we worked him up further with a PET scan confirming those findings I had spoken about. And he got immediately put on dabrafimib and trametinib under the protocol from MD Anderson, where we're a site for this protocol. We got him on protocol within 4 days, and then it's not completely inconsequential. There's parts where he had to be held on his treatment for hyperglycemia and some hospitalizations, but he did have a dramatic improvement on his scans, and to the point where the structural disease in the neck wasn't in the lungs was no longer seen. And so we're considering him for surgery, and he did undergo surgery with a thyroidectomy, neck dissection. Final pathology did show focal residual papillary thyroid cancer, but no elements of anaplastic cancer, and he's been doing very well, resumed on his treatment. This is just imaging. Again, this was pre-treatment on the bottom of the screen with the carotid encasement. And after the protocol, you could see the dramatic improvement in his scans here from that, where we felt that he would be deemed a surgical candidate. His vocal cord on the left was actually immobile prior to at presentation, and then after the treatment, it was still immobile. We were kind of hoping for the described and now published Lazarus effect. Dr. Zafario, Dr. Randolph have been involved with it, where some patients have had neoadjuvant treatment and have had a functional reconstitution of their vocal cord motion, but this patient did not. Still, I'm supposed to speak a little bit about nerve management. We'll talk about some involved issues when the nerves invaded. But for just a few general points I want to bring up before I show the video, I really focus mostly on meticulous hemostasis and actually parathyroid management. I dissect in a superior to inferior plane on cephalad to caudad, really trying to push the nerve into a predictable location where I'll eventually encounter it. So I don't actively spread and look for the nerve. And I do that for two reasons. One, I think it really decreases the disruption for critical blood supply to the parathyroids. And then I certainly see enough people when they start looking for the nerve and don't immediately find it, they start getting anxious. I just keep the case moving along with great hemostasis and looking in those natural tissue planes. And then I will identify, I always do find and see the nerve. And once I identify it, I really don't use much heat or traction on the nerve. I've gotten into a pattern once I find it at the ligament of Berry to frequently stimulate it about 3 to 4 times in the first couple of minutes, because I'm trying to bridge the gap between continuous nerve monitoring and intermittent nerve monitoring. So if I'm seeing an amplitude going down, I'm going to change my focus, technique, tension. And so you really want to hold on to signal because if you don't, you're going to be not loving the case as much. And it really decreases the permutations of what you can really do in that particular case once you lose signal. And so
Hey,
it
Joe.
does give you a lot of information. So yes.
Hey, Joe, do you ever use the nerve monitor before you've actually visually encountered the nerve?
Yeah, I do get a signal off the vagus in the beginning as well. Yeah, I do get a V1 signal, and that you don't necessarily, it's been well described, you don't have to, extensively dissect the vagus, but just you can get a quick signal at 2 milliamp super threshold amplitude on it. So I do, yeah.
Do you ever do the kind of the scanning technique to help you find the nerve or to give you an idea of where it might be in some of these more difficult cases before you see it visually, or not so much?
No, I really don't ever. I really just focus on the anatomy and the planes. And then eventually, as I said, I'll find the nerve. If you push the nerve into location, there's nowhere to hide, really. You want to get off the gland in that tracheoesophageal groove, especially on goiters and other big cases where it's going to be in a predictable location. And I love the cricoid. I think it's the most important landmark. Actually, it's got to go into the larynx there. And so that gives you the perspective of where the nerve's heading in. I like to find the nerve high, beware of extralaryngeal spreading of the nerve, obviously, in that area. All right. So with that, I'll just start the case here. I do a transverse incision low. I don't make the incision going up high for two reasons. It's cosmetically nicer, and also it gives you more access to level 5 in the back. I really don't use a bovie much at all, except for the beginning. Now, I do my neck dissections pretty much just with the scalpel, with a 10 blade or 15 blade. I like the 10 blade because it doesn't bury into the tissue. You can see in these anaplastic cases that there's a lot of scarring that occurs, kind of necrosis on the tissue. And I'm kind of defining some of the great vessels, getting it off there with the blade. It just gives a really, you really can't use hemostats much on this. I don't ever with my necks anyway. So I kind of like to use a scalpel for all the neck dissections. And once I've gotten the neck dissection completed, I think we got about 30 nodes or so out of this. I'll go ahead and look at the vagus again, but I wasn't getting any signal. Again, the person didn't have signal beforehand. Mm. I have gotten used to just taking the strap muscles completely with some of these. And unfortunately, I can't open the cricothyroid space very easily with some of the scar there. So I'm looking for big landmarks like the cricothyroid muscle, and I'm taking the strap muscles with me in these particular cases. It's newer for us to do these kind of anaplastic cases, and there's a lot of scarring present. But I'm trying to find the most natural tissue planes. I love jeweler bipolars for just some of the precision that they can give to kind of work through some of the planes. Even though the films looked pretty nice, it's a very scarred in tissue. And what I'm trying to do is bring these planes down into that tracheoesophageal groove. And when I get near the ligament berry, now we have the inferior constrictor cricopharyngeus defined. The nerve is going to come into view here. I'm just being very meticulous kind of in this area, even though the nerve wasn't working. I'm still hoping that it's going to. And from what I heard, his voice has improved. So maybe he has had some Lazarus effect or improvements. I tend to use just this bipolar and a scalpel. I'll use a lot too to sharply dissect off the tissue, including some of the muscle at times in this area. The nerve is right in that area there where I
Hey,
protect
Joe. Could I,
Mhm.
you brought up a good point, and I just wanted to bring it up and see if anyone would do anything differently. You mentioned you really don't treat the nerve here differently, even though not only was the vocal cord paralyzed pre-op, but you weren't getting any EMG signal. But you still treated it. It sounds like you're treating it with care, hoping that you'll get something back. You know, in some of the guidelines and some of the things we think about it, even if it's paralyzed pre-op, if you get some sort of EMG signal, you know, you try to preserve it, even if preoperatively it's paralyzed. And is that generally your thinking with, you know, maybe cases that aren't anaplastic?
Yeah, so if there's a grossly invaded nerve where I simply can't get any plane and I'm leaving gross structural disease, I usually would take the nerve. But
Yeah.
you know, in a situation where the nerve's not grossly encased, as this wasn't, I'm trying to see if we'll get signal back later and preserve it as best I can. Because you will get some tone that'll come through, even in an invaded nerve where someone has immobility of their vocal cord preoperatively. If you take that nerve intraoperative, they're going to have a degradation of their voice because it is getting some tone to the vocal cords.
Yeah.
But for this particular one, I just elected not to take the nerve just because of how it looked, and it didn't look grossly invaded the way other nerves have looked and ones that I'll show. So I'll just continue on with the end here of this. So as this kind of came up again, no signal on our you know our R1. So I did the V1 was nothing and nothing on R1 there. I've gotten the nerve all the way down here. This is where I sometimes will use a bovie at times to just get it off the trachea. And then as I've done this, it's interesting that giant cancer just went to this little scar ball, but there is still persistent papillary thyroid cancer. So the protocol won't work well with well-differentiated cancer. I continue on with the rest of the central neck. I went to the other side also to remove it. And on the other side, as I started to take down the superior pole, I found the superior nerve on the other side that's coming up right over there, which stimulated well. But then the gland looks quite normal on the other side, which is quite interesting how the protocol didn't necessarily affect it quite the same.
Mm-hmm.
So I think
Joe, do you always look for and try to visually identify the external branch of the superior laryngeal nerve during superior pole dissection? Do you stimulate for it? How do you manage it?
I do always look for it. I don't always necessarily find it. I will stimulate and look for it, but there's about a third of the case or so where it can sometimes be quite buried within the constrictor muscle, but I'm being very careful and make sure that it's not going to be taken within any of the vessels. So I don't identify it the way I will the recurrent nerve always.
Mm-hmm. Do any of the other panelists, I don't know if you want to chime in, do you have to either visually identify it or stimulate it? How do you deal with that superior laryngeal nerve?
Yeah, I'm like Joe. I'm always looking for it, but not hunting for it. I mean, I'm always watching for it. I don't go out of my way to identify it if it's not within the dissection of the superior pole. But I do like to, I like the fact that if you do use nerve monitoring, it's not just recurrent laryngeal nerve monitoring. It is superior laryngeal nerve monitoring as well. Although you can visually see the cricothyroid muscle contract or feel it. So even if you're not using nerve monitoring, I think you can more easily assess the function of the superior than you can the recurrent. You can stimulate the recurrent laryngeal nerve without nerve monitoring too by palpating the posterior cricoarytenoid, but that's not visible.
Mark, do you do anything differently with that superior pole?
Well, similar to, can't really add much to Joe and Lisa here. I do use the nerve monitor, and I do try to identify it in all cases. I think probably 60% of the time, 70% of the time, I think probably it can be identified, and I do make a conscious effort to try to stimulate it as well. And sometimes if I'm not able to find it, I'll sort of run the nerve stimulator over the inferior constrictor muscle there, the cricopharyngeus, and sort of kind of see where that nerve. And a lot of times, if you don't see it, it's underneath the muscle there. So
yeah, I think it's a nice that insertion of the sternothyroid muscle into the thyroid cartilage, kind of running parallel just inferior to that. Is I like to do that, to look for it and stimulate it and look for that cricothyroid muscle twitch. All right, Joe, sorry for the interruption. We'll let you continue.
That was it. The pathology just had shown that the neck actually had been negative. There's no focal residual thyroid cancer. And so this by Dr. Zafarios and the data from MD Anderson, this actually gives a pretty nice prognosis for many of these patients. And we've had some other ones that have been like this and other schedules. So we'll have to keep people updated.
Do you want to comment at all on the parathyroid glands there? I imagine with how, the poor planes and the thick kind of fascia and stickiness, that it was probably difficult to try to identify all the glands. Any thoughts on those dissections and tips for the parathyroids?
Yeah, so it's kind of a new world for me doing this. So like the first case I did, in this case too, identified one and I auto-transplanted. Before doing that, I actually took some frozens around it to see how it looked, because I didn't want to transplant something. I mean, this is anaplastic cancer, so I'm kind of cautious about where to go with it. On the other side, I was able to protect the parathyroids very well, but on that side where the lobe on the left where it was coming from, I did take one flat out in the central neck, and then the superior one I auto-transplanted after I ran some frozens on it.
Yeah, there were a couple questions in the chat. One was if you guys all use some sort of magnification during your thyroidectomies, during your neck dissections, whether it's microscope or loops.
I always use I wear 2.5 loops.
Yeah.
Yeah, me too.
Okay.
Same. I wear 3.5 loops.
Okay. And then one other question, then we'll move on. In particular at the ligament of Berry. Joe, you kind of talked about how you like the scalpel, but then sometimes once you get past the ligament of Berry or past where the nerve is safe, you might use a bovie on the trachea. Does anyone else, what are your favorite instruments at the ligament of Berry? Mark, do you have a specific instrument you want to use in that area?
Yeah, I think it's not one size fits all for me. I mean,
Sure.
I'll usually try to I'll use a peanut, and sometimes I'll try to mobilize the nerve a little bit and kind of push it away a little bit, and release some of the sort of attachments to the nerve to get it pushed away. And then oftentimes I'll use a bipolar right there too, and a knife. Sometimes also a really fine mosquito. It depends on the situation.
I think in that area, it's really important to kind of dig into the gland a lot and move up on the gland a bit into the perithyroid sheath. So you're releasing some of that fascia, and that'll release the nerve down quite a bit at times because it'll be quite adherent in many cases. So I don't like to directly touch on top of the nerve, but more on top of the gland and release the sheath off of it.
Yeah.
Yeah.
Lisa, anything to add?
Yeah. Yeah. No, I think I tend to use a fine dissector and the bipolar, but I like the comments that both Mark and Joe just made that, you know, really trying to release that nerve down is very helpful. And you can sometimes push it down a little bit, you know, just push it away. So, yeah.
Thank you, guys. I think in the interest of time, let's move on to the second section. We're going to let Lisa share her slides and talk a little bit more about the central neck and lateral neck.
Okay, can you all see that now? Good, good. Thank you, Whitney and friends. And I am going to go from what was a very sublime presentation by Joe with an elegant dissection to a maybe more basic level. But I wanted to talk about a few things that I think are key to preventing recurrence or persistent disease in thyroid cancer, because there are some nuances about the neck dissection for thyroid cancer that are different from that of mucosal cancers or salivary cancers or melanoma. And I think the areas I want to highlight are the, as Whitney said, the retroneural portion of right level 6, and also the retrocarotid area where level 6 sort of borders with level 4. And then in the lateral neck, I think areas that can be prone to missing disease are in the medial level 3 in the paralaryngeal space, and the inferior neck in level 4 and 5B along the transverse cervical artery and vein. So I have some pearls here from a prior webinar that the AHNS sponsored, and I think there's so much to talk about in the central neck that I really want to focus my comments on a couple of issues, including the use of ultrasonography, because I can't resist talking about ultrasound in any talk about thyroid cancer, but also in the central neck microdissecting and incorporating the packet deep to the recurrent laryngeal nerve. And so I'm going to start with just a case of a patient that actually had very advanced papillary thyroid cancer. It was not really worked up initially because she had advanced breast cancer as well, and it was not thought that she had a good prognosis from that cancer. But as she continued to survive and her metastatic breast cancer regressed, this became more apparent, and she did develop in the process loss of vocal cord function on her right side. I was relieved to hear that Joe doesn't always preserve the nerve, because this woman had absent mobility on the right in preoperative laryngeal evaluation. And as you can see from this tumor, her recurrent laryngeal nerve really was expected to be encased on the right side. So her disease extended into her superior mediastinum, and the dissection required a partial sternotomy, a manubriotomy. And I present this case just to show the right level 6 compartment. I don't know if you can see my arrow, but the carotid artery and into the innominate artery with the subclavian artery coming off here. This compartment really was filled with tumor and adherent lymph nodes. And this is what we would like to address in the central neck on the right, all the way down to the prevertebral fascia and what little portion of the esophagus is visible on the right side. And so in a patient who does have a functioning recurrent laryngeal nerve, the goal is really to achieve that same level of clearance, but just preserve that nerve running typically obliquely through the right level 6 compartment. And so this is a different patient who had a thyroidectomy and followed by radioactive iodine treatment for papillary thyroid carcinoma, where her central neck really was neglected. And so this is persistent disease in her central neck. And we see on this upper panel a large metastatic node in her right level 6 in the paratracheal space between the carotid and the trachea. We see here a large metastasis in the left level 6 paratracheal space, and then in the pretracheal space as well. And so here's a video just showing that ultrasound view. Unfortunately, we can't see the recurrent laryngeal nerves on ultrasound or any other imaging typically, but you see disease just encircling her trachea, and you know that those nerves are running through in between or against the metastases. Here's this left-sided mass. And so this was not a video, but just a still image of her surgical specimen after bilateral level 6 dissection. Her lymph nodes did have extranodal extension. The masses were adherent to her trachea, extending posterior to a nominate artery, adherent to both recurrent laryngeal nerves. Sometimes it's a little bit difficult to tell whether it's scar tissue from the prior thyroidectomy versus tumor, but when dissecting inferior to where the prior surgery had ended, there was still adherence. And so again, sort of similar to Joe's comment previously, I am willing to switch sides of the neck depending on whether I think that I'm going to lose function of the nerve on one side. In this case, the greater bulk of disease was on the right side, but it turned out that the more adherent disease was on the left side. And so I did use nerve monitoring as I routinely do, but in this case, I confirmed that there was integrity of function on the right side before finishing the dissection on the left side. And we did lose signal to the larynx on the left side, although the nerve was preserved. I did not identify any parathyroid glands during this dissection. It's very difficult in the revision central neck to predict where those parathyroid glands are going to be. But fortunately, her parathyroid hormone level was normal at the end of the dissection, indicating preserved function. And she did recover vocal cord mobility by 3 months postoperatively. So in this drawing, you can kind of see the diagonal or oblique course of the recurrent laryngeal nerve on the right. And I like to draw attention to this excellent treatise on management of the recurrent laryngeal nerve or nerves during thyroidectomy and thyroid surgery. And this is an AHNS consensus statement published a few years ago. But the diagram here sort of illustrates how the recurrent laryngeal nerve on the left side does travel more vertically and more truly within that tracheoesophageal groove, which is how it's often described. But on the right side, that recurrent laryngeal nerve travels more obliquely and not so much in the tracheoesophageal groove. And there is quite a bit of tissue deep to the recurrent laryngeal nerve between the nerve and the prevertebral fascia. So that's important because that is a source of a significant lymphadenopathy and often metastatic disease. So in dissecting,
so Lisa, you're pointing out,
this is
that I love that figure because it's not just the oblique nature of the nerve, but also the more ventral course downward, by the innominate and subclavian, because it's coming over the trachea. And so more ventral, kind of lower in the neck as it's heading up towards the ligament of Berry. And so that's where, if you're hesitant to go deep to the nerve, you really can miss some disease. That's a nice picture.
Yeah, no, thanks. And that's why I hope that the listeners can review this reference because it's an excellent paper with nice diagrams. I think this sort of inverted pyramid shows it well. And so similarly, when dissecting level 6 on the left side, it's fairly straightforward to dissect and deliver the lymph node packet and sort of just transpose it over the recurrent laryngeal nerve as you dissect typically from distal to proximal or from superior to inferior and lateral to medial. But on the right side, it's really essential to mobilize that recurrent laryngeal nerve and transpose that packet of tissue from underneath the nerve. And so this is, I think, the nicest diagram that I could identify. And I'm sorry, I tried to take a video of performing this procedure and it just didn't show well. So I think the still images do more justice to it, but it can be necessary to completely release the recurrent laryngeal nerve. I do tend to use vessel loops to just to lift up the nerve, and really don't put a clamp on the vessel loop because I don't want to inadvertently exert too much traction on it. But it can be helpful just to sort of move the nerve back and forth from medial to lateral as you're sliding the lymph node packet underneath it. And So that was my sort of commentary on the central neck. And the other area that I think is prone to persistent disease, a couple areas in the lateral neck on thyroid cancer neck dissections, is medial level 3. I think there's a very easy tendency to dissect from lateral to medial. And once you have the packet levels 2, 3, 4, and 5B off of the jugular vein, really to sort of come over the carotid and then just transect the packet up near the hyoid bone and forget that there can be lymph nodes medial to the carotid artery in that sort of paralaryngeal space. So this is a lymph node on ultrasound that's subtle, but you can see it's an oval lymph node, but it has microcalcifications in it. And this was a metastatic node in a patient with papillary thyroid cancer. Here's another patient who'd had a thyroidectomy sometime previously and had persistent thyroglobulanemia, and the referring physician couldn't identify where it was coming from. They'd even gotten an MRI scan, which was read as negative, but if you look closely, there is this abnormal node in the paralaryngeal space. And then a subsequent CT scan also showed a very subtle finding in the paralaryngeal space that was, again, read as negative by the radiologist. But on ultrasound, you can appreciate this mass just medial to the carotid bifurcation and lateral to the piriform sinus, this suspicious nodule here, which did show papillary thyroid carcinoma. It was 1.2 centimeters in the sagittal dimension. And so that's the medial level 3.
Sorry to interrupt. Do you think about the superior laryngeal nerve in that area?
Absolutely.
Yeah. How do you deal with it there?
Yeah. So I do like to follow the superior thyroid artery from its, takeoff from the external carotid artery and down toward the thyroid. And whether it's a revision case where it was already ligated previously, you know that superior laryngeal nerve is going to be just deep to that. And so I do seek it and seek to protect it during the dissection medial to the carotid and sort of following that superior thyroid artery. It kind of makes sense that this is where lymph nodes would tend to go, because that lymphatic drainage along the superior thyroid pedicle is going to go right to this area. So it's an area that maybe isn't thought of as commonly in management of squamous cell carcinoma, but is fairly often affected in thyroid cancer. And then the other area that is similarly commonly affected for similar reasons is along the transverse cervical artery, which, as we know, comes off of the thyrocervical trunk, but also coming off the thyrocervical trunk is the inferior thyroid artery. And so again, it kind of, to me, makes logical sense that there would be lymphatic drainage along that inferior thyroid artery / vein course, and the lymphatics would then travel out along that shared pathway from the thyrocervical trunk to the transverse cervical vessels. So let me just play this again. Here's the subclavian artery. Here's the thyrocervical trunk. Here's the transverse cervical artery coming over the scalene muscle. This is in the patient's left side of their neck. And I'll play it one more time just to show that inferior thyroid artery kind of courses anteriorly, whereas the transverse cervical artery courses posteriorly. So that area is very important to dissect thoroughly to retrieve disease in that level 4 into 5B sort of location. And here I do have a surgical video. One point that I tend to make is that it's my practice to transect and remove the omohyoid muscle to give the best access to that level 4 and 5B location. It also ensures that you're not going to miss these nodes that are immediately under the omohyoid or in the space medial to the carotid sheath. So there you're seeing a couple of metastatic nodes kind of hiding under that omohyoid. But then going on to the next video, and just before I do so, I'll orient you that this is the patient's left lateral neck, and the patient's head is up here at the bottom of the screen, and their chest is at the top of the screen. And so
Joe,
here's
Mark, do you guys routinely transect or take the omohyoid when you're doing level 3, 4?
Yes, I always do.
Yeah.
I do also, actually. I think it's a great idea.
Yeah.
Thanks. So this is just showing that the jugular vein has been dissected out, the vagus nerve behind it, and then you have the carotid behind that. And just rotating the carotid up, you have the sympathetic trunk and this very large lymphatic thoracic duct, which has been ligated. I ligate it when necessary, when it's draining nodes, and I test at the immediate time of ligation with Valsalva maneuver, because I think that's the best time to catch and treat any kind of chyle leak rather than waiting until the end of the case.
Yeah, can we stop there for a second? I just wanted to ask the panelists each how you manage if you need to ligate the thoracic duct. What's your preferred, instrument of choice? Do you tie it off? What do you do? Do you staple? Do you like harmonic? No harmonic? Hate harmonic? What are your instruments of choice there?
I think it's very common. Certainly, I tell the residents if they're not seeing chyle, they're probably not doing a thorough enough dissection in that area. But some of them are not just the thoracic duct, but large lymphatics. I actually like titanium Liga clips, and you have to be careful that you don't shear them because they don't take a stitch very well. So I like to use titanium Liga clips or sometimes a suture tie around a munion. But I would take every bit of time that you need to close it off before you move on.
Mm-hmm. Mark, any thoughts?
I typically use suture ties. Although one of my younger colleagues uses the ligature and says that it works great, so I think that's another option. But I use ties.
Okay.
I hate chyle leaks so much that I'll do belt and suspenders. I'll do ties and ligature, but I'll use clips sometimes. But I just find that it's sometimes hard to place them in the angle that you want to. So when possible, I prefer to tie. So I'll continue the video here, or maybe I have to replay it here. So anyway, there was that large thoracic duct. But what I was trying to demonstrate here was also that transverse cervical artery. Now, this patient had a very long neck and a very high branching of her thyrocervical trunk. So after we sort of reflect the thoracic duct again here in just a moment, you'll see she has this thyrocervical trunk here and the inferior thyroid artery coursing anteriorly, and then the transverse cervical artery coursing posteriorly. And of course, you see the phrenic nerve here running over the scalene muscle. But it's really, I think it's important to skeletonize these vessels and really deliberately take that entire packet rather than just sort of bluntly taking that packet down in that supraclavicular area. So those were my sort of highlights, and didn't want to run on too long. So that's all I had prepared.
I really appreciate it. Mark, we'll move on to your videos. While you're switching over, there were a couple questions in the Q&A. One is just if any of you could comment on your maybe tried and true techniques for identifying parathyroid glands when you're doing those more extensive central neck compartment dissections. Any specific techniques that you use that have really helped you? Lisa, you're nodding your head there.
Yeah, I mean, I could just start with some of the sort of, basically the superior parathyroid glands are more consistent in their location and easier to preserve their blood supply when you have to do an extensive central neck dissection. So I do prioritize those superior parathyroid glands and typically ensure that they are, and then dissect inferiorly from there. It's much more difficult when there's a lot of adenopathy to preserve the blood supply to the inferior parathyroid glands. So depending on how much adenopathy there is, if I'm comfortable that I've saved both superior parathyroid glands, I'm not as deliberate and sort of digging parathyroid glands out from a packet of metastatic nodes. But yeah, following that inferior thyroid artery is still kind of the best landmark that you have, and any branches thereby.
Thanks. All right, Mark, we'll turn it over to you.
Well, thanks. Well, it's really hard to follow Lisa and Joe, but I'll try to give a few thoughts about how to manage the trachea in when dealing with thyroid cancer. Are you able to see my screen, hopefully? So I
Yeah.
have research funding from Merck and Eli Lilly for clinical trials. And so just a brief slide, just I think everybody's aware, but just to remind everyone, the blood supply to the trachea comes posteriorly and posterolaterally, and that's important to remember as we're considering tracheal resection. The other thing I want to remind everyone is the Grillo staging. So this is probably 40 years old now, a little bit more than 40 years old, but I think it's still very pertinent. And I think it's a nice way to think about tracheal invasion with thyroid cancer, where stage 1 is abutting the perichondrium, stage 2 sort of getting between the tracheal rings there, stage 3 between the tracheal rings and actually submucosally into the trachea, and then stage 4 actually into the tracheal lumen. When we talk about shave versus resection, and I do have a video, I'm going to spend about 5 minutes on these slides and then I'll go to the video. But the goal is to remove all gross disease. In some cases, we can tolerate, R1 microscopic margins. For SHIN1, where you have the disease that's sort of adherent to the perichondrium, I think it's clear that we can shave those tumors most of the time. There's not really a consensus for SHIN2 when there's sort of disease that's sort of interdigitating between the tracheal rings. Sometimes those can be shaved. Sometimes a more formal tracheal resection is required. It depends on the circumstances. And then typically a more formal segmental tracheal resection is the most common. Also, window resections can be done in some cases for SHIN3 and SHIN4 disease. So this is an example of SHIN2 tracheal involvement where you can see up on the tumor here where the tumor is it's like these little mountains of disease here where the tumor had been sort of interdigitating between the tracheal rings here. And so that can be shaved, but it requires a pretty meticulous shave dissection and certainly very high risk of leaving microscopic R1 disease in a case like this. But for somebody who's had more indolent disease and or is expected to have more indolent disease and is older, this may be a very reasonable option. So in terms of sort of segmental resections, formal resections of the trachea, window resections can be done. I don't do a lot of window resections. I'd be interested to ask Joe and Lisa later if they do many windows. I think when the disease is really anterior, you can do a window resection. Unfortunately, most of the time with thyroid cancer, unless the tumor is in the isthmus invading the trachea, it's usually the lateral trachea and even some of the membranous trachea that's involved. So that does not lend itself so well to a window resection. So usually for those, segmental resection is needed. A couple of, I think, important points. Management, and I'll talk about a few of these in the video. Management of the endotracheal tube really, the tracheal resection really starts with the management of the endotracheal tube with the prepping and draping. And I think, and I'll show a picture of this in the video, but it's really important to prep and drape the tube out so that as a surgeon, you can manipulate that tube, push it in, pull it out. And I think that's an important part of the procedure. And then, of course, minimizing tension. You're never going to have a completely tension-free closure, at least rarely, but certainly in all cases, releasing the inferior in the thoracic trachea anteriorly. Usually that can just be with blunt finger dissection. Supralaryngeal, suprahyoid muscle releases can be done, but those are associated with dysphagia. So I don't typically do those in most cases, and they're typically not necessary. But in some cases where there's longer resections and more tension, definitely an option. Just the patient should be aware that they're going to have some dysphagia, which is mostly temporary, but some long-term, a little bit of dysphagia there too. And then I personally do not use Grillo stitches, the chin to chest sutures, but I know that some people do use those, but I have not used those. in terms of a tracheostomy tube, certainly we're all aware that if you think you need a trach, then it's better to do it. So it's hard to say not to do a tracheostomy tube, but with tracheal resection, if it can be avoided, it's generally better. It's better for the integrity of the closure. It's also, you're not bathing the closure in sort of saliva there. And as long as you have one intact recurrent laryngeal nerve, you generally don't need a tracheostomy tube. And then immediate extubation is preferred. I don't really see a reason to leave patients intubated overnight or anything like that. I think that you're leaving pressure on the tracheal closure if you do that by having the balloon up, and that's just it's going to affect the vascularity of the trachea and also directly put pressure on the tracheal closure with potentially that balloon. So I've never recommended keeping patients intubated.
Mark, can I stop you just real briefly? This relates to a question in the chat as well, but you talked about, no trach as long as you have one Arlen that's intact. Let's say a hypothetical scenario where you've got both Arlens out for whatever reason. It would be interesting to hear the panelists talk about, would you always trach in that situation? Or would you, if you were given that scenario, would you pick trach every time? Or would you favor, extubate the patient and see how they do? What do you guys think? It was not necessarily in a tracheal resection case.
Yeah. I was going to say, if I'm doing a tracheal resection and I have a significant concern for bilateral nerve paralysis, I'm probably going to do a trach. But other cases, I don't necessarily think you have to. I think it depends on the circumstances, and certainly Joe and Lisa may chime in here.
Any thoughts, Joe?
Sorry, I missed the question. What was your question, Whitney?
The question relates to if you had concern for a bilateral vocal cord paralysis during surgery, what would your airway plan be? Would it be to always trach, to extubate and see how it goes? This was a question related to the Q&A, and I thought that
it's a general question, Lisa, that somebody asked, not necessarily related to tracheal resection.
Yeah.
I've been very fortunate that I'm such a stickler about nerve monitoring that I don't really put but I do get sometimes solitary nerves. I haven't been in that position with my own patient, but I have been called into those cases from other surgeons. And sometimes they need to be reintubated. Sometimes you could get them by with CPAP. Sometimes they need to be trach. Not always, about 40% of the time the literature suggests that you need a trach. And I try whatever I do, and I've been fortunate yet not to be in one of those positions with my own patients, but I've had to manage patients in those spots.
Yeah. Thanks, Joe.
Yeah. I'm the same. Try to avoid a trach, but like Mark said, if you think trach, sometimes it's better to do it. You can, if you finish these cases late in the day, it's difficult because the anesthesiologist will often want to leave the patient intubated. You don't want to have an emergency airway overnight. So that, I do think about the timing of the case up front. If I think that there's a high risk for bilateral vocal cord paralysis, and try to avoid having it be one that I'm going to, end late in the day, just for better availability of all hands and expertise. And I do, as Mark pointed out, try to extubate in the OR, extubate over a tube changer if you are concerned that they're not going to fly, and if they have a difficult reintubation, is an option. Just one other point.
Yeah, that point Lisa makes is very important because they may not fail right there immediately, but it's going to be in the PACU or several hours later sometimes. So you're doing it early in the day would probably be wise if you're dealing with a solitary nerve or something like that.
Yeah.
Thanks.
Yeah, great points. Couple of slides. Let me see if I can move these slides. Everybody can still see the presentation. Yeah. So esophageal invasion often accompanies tracheal invasion. We recently studied this. I think I have a slide or two about that in a second, but probably 30 to 40% of these patients who have tracheal invasion also have esophageal muscularis invasion. It's usually not intraluminal. It's usually between the muscularis and the submucosa. You can sort of develop this plane here. and the tumor is usually just in the muscularis. And so it's often necessary to remove esophageal muscularis. And this is just a pictorial example. I think I have a little bit of this in the video where you can sort of get in the plane between the muscularis and the submucosa to dissect tumor off of the esophagus. And that's often necessary when doing tracheal work as well. We published, or we actually presented this paper at the international meeting over the summer. This was 110 patients. Hopefully it will be published soon, who had segmental tracheal resection only over the last 20 years. And just to say that, these are complicated cases. And so of these 110 patients, there were 3 patients who had perioperative mortality, not immediately during surgery, but within either the hospital stay or within the first couple of months of surgery. So, and then there's a high rate of return to OR and other, complications that, that I think we need to be prepared to manage. So they are complicated cases, but I think this was our survival in this particular study. These were all histopathologies. So there were probably 70–80% of these were papillary and follicular, but there were some medullaries and anaplastics in here too. But 3-year survival, overall survival 85%, and local regional control a little over 90%. So I think it's worth doing in a select group of patients with local regionally advanced disease. And with that, I am going to share quick video for just a couple of minutes. Let's see if I can get it to go here. So you can see the video here. So I'm going to scroll up. So this is an example of a patient who's a 53-year-old who had not had previous surgery and had a right vocal cord paralysis. So this is the CT scan. Scrolling down, we can see coming up here a right vocal cord paralysis there, which you can see on the CT scan. And then as you get a little bit lower, there's the cricoid, and you start to see there's the tumor there. And it's a pretty long segment of tracheal involvement here, intraluminal. So this would be a Shin type 4 involvement. So we ended up resecting 9 rings here, which is the most I think I've ever resected in a tracheal resection case. It's not just about the number of rings, though. It's really this was about 4 centimeters. So I'm going to sort of show some of the steps that we use. So sometimes you can resect these in block with the trachea, but I typically don't. I typically will resect the disease off of the trachea, and this is what we're showing here. So these are the head of the patient is to the right, the feet are to the left, and these are some of the structures here. And as I was mentioning before, we're often dealing with tumor that's also involving the esophageal muscularis. So this is removing a little bit of the muscularis with the tumor, and then I go back and take some additional sort of that's a parathyroid gland right there. Take some additional margins with a knife following this, but so I typically will remove the tumor from the trachea, from the esophagus. And then go back and do the tracheal resection. So although it can be done in block, I think it can be a little bit harder. So this is an example of some of the esophageal muscularis here. This is the nerve on the contralateral side, which is intact, having one intact nerve being important. And this is that illustration of sort of getting in that plane with between the muscularis and the mucosa. You can do it with a knife. You can also do it with a gently and bipolar, but I think a knife is usually pretty good. A lot of people will use bougies. I typically don't, and I know that there's some people who would put a bougie in the esophagus. I think it changes the sort of the planes, and I like dealing with a very sort of flaccid esophagus is I'm sort of using a knife to dissect sort of muscularis off of an esophagus. So this was taking some extra margins here. So in this, you can see here in the middle is sort of the submucosa sort of pooching out, and this is that plane between the muscularis and the submucosa that you can get in nicely. I typically do a betadine lavage after a case like this, but you typically will know if you have a micro leak, because the esophagus will no longer have all this air in it. So as long as you see this esophagus nice and pooched out like this, you're okay. You don't typically have a leak there. So so moving on a little bit. So this is taking off. This is the sort of the next step, is sort of getting in a plane between the trachea and the esophagus here, and then sort of making sure that you mobilize the functioning recurrent laryngeal nerve off of the trachea, especially because most of the time you really are resecting the first ring, and so most of the time you don't. I think in this case we resected just a little bit of cricoid, but you really do got to have to mobilize that nerve so that you don't end up injuring that nerve whenever you do the tracheal closure. So this is a little bit of esophageal muscularis that's still on there. There's the intact nerve on the left side, and there's the plane between the trachea and esophagus. And so now you're sort of ready to do your tracheal resection, but you do need to, before you open the trachea, release the anterior attachments. And this can typically just be done bluntly with finger dissection, reaching down into the superior mediastinum. Rarely, in this case, it was a really long resection, so we did do a suprahyoid release. And when you do that, you could do either suprahyoid or supralaryngeal release. This is actually suprahyoid, so above the hyoid, releasing these muscles. But these patients will have some dysphagia associated with that. And so this is kind of similar to what you would do with the laryngectomy, and you can see. So these are in this case, these are the 9 rings that sort of are resected here with like a dot on each ring. And now we're gonna draw it out here. I usually make I'm gonna skip ahead a little bit. So this is the endotracheal tube that's sort of been prepped out here. We are using a NIMS monitor. You can continue to use the NIMS tube even after the tracheal resection. You just need to slide the tube back in. So you make your inferior cut here, and you put the balloon down. Obviously, as a surgeon, if you prep the tube in, you're controlling all this. So you're putting the balloon down yourself. You're pulling the tube back. You're intubating the patient with a wire reinforced tube here. And then you're sort of beveling up as you come along the mucosa, if possible, to try to save as much of that mucosa as possible. So that's the inferior cut, and then you're intubating the patient with the wire reinforced tube. And then you can go back. You can look inside and sort of see if you need to kind of look at your margins and how much you need to take. In this case, we're taking it right off of the cricoid, which is the upper cut, which is the second cut. And then here you still see the endotracheal tube from the surgery, which is here. So we try to keep the patient intubated, and the NIMS tube is in there. If the patient accidentally gets extubated, you can always reintubate. But that's this is actually the tracheal resection with a little bit of cricoid here, and you can see the tumor sort of creeping up under the cricoid there. So once skipping ahead, so here's the specimen with the tracheal disease. So then you're putting the tracheal back together, which is the most difficult part of the dissection. I do put a stitch on the endotracheal tube just to sort of keep track of it, and so I can actually pull it if I need to during the case. But I use, for closure, in the last minute here, I use Vicryl sutures. So you go out to in to out. So you want the stitches on the outside of the lumen, and I start posteriorly, and I come on the right side. You're going to be going clockwise from posterior to anterior. On the left side, it's going to be counterclockwise from posterior to anterior. And then as we're doing that, So we're putting, I use 3/0 and 2/0 Vicryl stitches, putting the stitches in. And I think it's very important to keep track of all these sutures. You have to have a sort of a specific technique for doing that. Usually you keep the mosquitoes on a straight clamp and you keep them in order so that you can, when you sew them in, you can sew them in from posterior to anterior. So, and I'll skip ahead a little bit. So this is the start of sewing it in posterior to anterior. So starting on one side or the other, you can start on the right or the left. And you go, again, on the left side, you're going counterclockwise, on the right, clockwise, from posterior to anterior. And then once you get to the anterior trachea, then just moving this video forward a little bit. This is actually doing the other side now. You can see the trachea starting to sort of come together. And then once you get to the anterior trachea, you can pull the endotracheal tube back out. You can, you cut the stitch that's on the endotracheal tube and you reintubate the patient. And then you put these anterior stitches in. And I typically go through 2 tracheal rings here for these anterior stitches just to give it more strength. And I go completely around the cricoid. I do not try to go through the cricoid because the cricoid will crack sometimes if you do that. So that's mostly what I wanted to show. And I do often put, some kind of a muscle flap, either strap or sometimes the sternal head of the SCM, or sometimes a pec flap in really major cases to over the closure. So that's basically what I wanted to show today.
Mark, thanks so much. And I think in the interest of time, we'll go ahead and close this session. I have a lot of questions, but I'll have to ask them later. I really, really appreciate all the panelists and their input. Again, honored to be a part. Hopefully you guys learned something and got something out of all these expert techniques. And with that, I think we'll say good night.
Thanks, everybody.
Thank you.
Thanks, Whitney.
Thanks,
Really
Whitney.
enjoyed it.
Thank you, guys. Nice job.